Pupil for Pupil by Dr. Dalia. She is Associate Professor at Government TD Medical College, Alappuzha. As you know, it is very difficult to understand the pupil and its abnormality. I think Dalia can go through that session, difficult session. Okay, over to Dr. Dalia.
Thank you, Mali Madam, for the opportunity. So, from our undergraduate dates itself, we are familiar with examination of pupil under all these headings. So, I'll pertain only to the reflexes part due to want of time. These are the smooth muscles of the pupil include the sphincter pupillae, which have got the parasympathetic, and the dilator pupillae, which has got the sympathetic supply. Pupillary reflexes, mainly important are the light reflexes and the near reflexes. The light pupillary reflex, when light is shown into one eye, both pupils constrict. In the same eye, it is direct, and the other eye, it is indirect or the consensual reflex. The direct and consensual are identical in time, course, and magnitude. And the both pupils, when illuminated simultaneously, the response summates. The first order neuron starts from the photoreceptors. The first order neuron starts from the photoreceptors, then come to the pretectal nucleus, which is in the dorsal portion of the midbrain at the level of superior colliculus. Internuncial neurons go to the Edinger-Westphal nucleus on both sides. Here there is a crossing, and in the chiasma also there is crossing. And from the Edinger-Westphal nucleus by the oculomotor nerve comes to the ciliary ganglion, its synapse here, and by oculomotor comes to the sphincter pupillae. Near reflex is actually synkinesis than a true reflex. It is activated with gaze change from distance to the near. It includes both accommodation and the convergence reflex. The presence of visual acuity is not a prerequisite for near pupillary reflex, and the midbrain center for near reflex is more ventral than the pretectal nucleus, and that is the reason we get a light near dissociation. So, we will go to the pupillary reflex abnormalities, which include both afferent and efferent pathway defects. The afferent pathway defects include the total afferent pupillary defect or the relative afferent pupillary defect. Total afferent pupillary defect, otherwise called the amerotic pupil, it is caused by a total optic nerve lesion or a severe retinal lesion. And it is characterized by total loss of vision, that is no PL vision in the involved eye. The direct reflex in the affected eye and the consensual in the opposite eye is absent. That is, when the affected eye is stimulated, there will not be any reaction in both eyes. But when the normal eye is stimulated, you will have the reflex, the reaction in both the eyes. In diffuse illumination, both pupils are of equal size. That is, there is no anisocoria, and the near reflex will be normal in both eyes. In relative afferent pupillary defect, commonly called as the Marcus-Kahn pupil, it is a paradoxical response of pupil to light. The cause is an incomplete optic nerve lesion or severe retinal disease, which is demonstrated by the swinging flashlight test. Normally, the both pupils will equally contract when light is shown to the pupil, and the light shown pupil will tightly constrict. RAPD, when there is an RAPD, the affected pupil will dilate on transfer of light to it from the normal eye. You can see when this is normally, and this is dilating when light is transferred to the affected eye. And the eye with RAPD is called the Marcus-Kahn pupil. It is an earliest indication of optic nerve diseases even when the visual acuity is normal. This is grading of RAPD. Grade 1 is a weak initial constriction followed by greater dilatation. Grade 2, just an initial pupillary stall. When it immediately dilates, it is grade 3, and when there is no reaction to light, it is grade 4. Quantifying RAPD is by using neutral density filters of varying strengths. The principle is the neutral density filter will grade light intensity, degrade the light intensity in the normal eye, and this will simulate an afferent defect in that eye. And when this apparent defect in the normal eye balances the real afferent defect in the affected eye, the Marcus-Kahn pupil disappears. Swinging flashlight test is done to demonstrate RAPD, and neutral density filters of increasing strength are placed over the normal eye, and you repeat the swinging flashlight test. The end point is the Marcus-Kahn pupil disappears, and there is equal reaction in both eyes. And the strength of the neutral density filter over the normal eye at the end point quantifies the amount of RAPD. Wernicke's hemianopy pupil is due to lesions in the optic tract, and in a right optic tract lesion, the pupil reaction will be absent when there is light stimulation from the left half in both eyes because of the crossing nasal fibers and the ipsilateral temporal fibers. Now, efferent pathway defects are characterized by direct, consensual, and near reflex on the affected side being absent, and on the normal side, all the reflexes will be present. The pupil will remain fixed and dilated, as you see in the picture, and the anisocoria that increases in bright light because the normal pupil will constrict. It can be because of pathologies in the sphincter. It can be in the short ciliary nerves, ciliary ganglion, or oculomotor nerve. Use of pharmacological agents can also mimic dilated pupil. In a third nerve palsy, the pupil will be mid-dilated and there will be anisocoria. Direct, consensual, and light reflex and the near reflexes will be affected. There will be associated ptosis and extraocular motility affection, and it can be differentiated from pharmacological mydriasis by using 1% pilocarpine. A third nerve palsy pupil will constrict, but a pharmacological mydriasis will not. Tonic pupil, this is due to damage to the ciliary ganglion and short ciliary nerves due to viral infections, trauma, diabetes, and idiopathy. The affected pupil is larger. The reaction to light is absent. The near reflex will be very slow and tonic, and there is an accommodative paresis. And this tonic pupil shows cholinergic supersensitivity of the denervated muscle to low dose pilocarpine. In Holmes-Addy syndrome, it is usually unilateral, with healthy females being more affected. There will be associated diminished or absent lower deep tendon reflexes. Associated autonomic dysfunctions may also be present along with this. No treatment is generally required. When you have a bilateral tonic pupil, always check syphilis serology. Near vision difficulties can be addressed with the use of spectacles and low-dose pilocarpine or sunglasses to improve the photophobia. Excessive sweating, thoracic sympathectomy can also be done. Now, coming to light near dissociation, that is, the accommodation reflex will be present, but the light reflexes will be absent. The common ones are the Argyll-Robertson pupil. A bilateral total afferent pathway defect can also mimic this. It's common in lesions of dorsal midbrain paranoid syndrome. And you can also get this in a third nerve palsy with aberrant regeneration. In adduction, you will have a pupillary constriction because of aberrant regeneration from medial rectus to the sphincter muscle, which is called the pseudo-ARP or the Sarnicki sign. It's a bilateral myotic pupil, which is often irregular. The near reflex will be brisk and normal. Light reflexes are absent. The visual acuity will be normal. And in long-standing cases, iris atrophy and transillumination defects may be present. Now, coming to the sympathetic, so that finishes the parasympathetic pathway. Now, coming to the sympathetic supply, which starts from the first order neurons from the hypothalamus down to the ciliospinal center of the buds from CA to T2. From here, it passes along the thoracic sympathetic chain, along the apex of the lungs, it comes to the superior cervical ganglion, synapsia, and postganglionic fibers along the internal carotid plexus, cavernous sinus, where it then leaves and joins the ophthalmic division of the trigeminal nerve, the long ciliary nerves, and come to the dilated pupil. Few fibers also go to the Muller's muscle on both the lids. You also have pseudomotor fibers coming from the superior cervical ganglion to the glands of the face. And accordingly, you can have lesions central, preganglionic or postganglionic. In Horner syndrome, which is oculosympathetic paresis, it is usually unilateral. There will be mild ptosis because of the weakness of the Muller's muscle, slight elevation of the lower eyelid because of the upside, it is called the upside down ptosis, miosis because of the unopposed action of the sphincter, anisocoria, which is more in the dim light. The pupillary light reflexes will be, and near reflexes will be normal. And in congenital cases and long-standing cases, you can have hypochromic heterochromia of the affected iris. And when there is a lesion below the superior cervical ganglion, reduced ipsilateral sweating of that side of the body also. Now, associated features with when there is central Horner's preganglionic, it can be a preganglionic, it can be a sign of lung malignancy also. Now, Horner's, the associated features, you can confirm the diagnosis with apraclonidine or cocaine, and 1% hydroxyamphetamine will help you to differentiate whether it is preganglionic or postganglionic. Now, Hutchison's pupil, which is very important, it is useful in assessing head injury. In stage 1, when there is an increased intracranial tension, the ipsilateral pupil constrict initially because of irritation, but the contralateral pupil will be normal. And as time passes and the intracranial tension rises, because of the parasympathetic paralysis, the ipsilateral pupil dilate and contralateral pupil starts constricting because of the irritation spreading onto the normal side. And in stage 3, because of parasympathetic paralysis, both the pupils will be dilating. So always avoid mydriatics in head injury as far as possible, as the pupil needs repeated assessment. In diabetes, the pupil can be of varying, can be constricted, tonic, sluggish reaction, and in usually the third nerve palsy is pupil sparing because of the ischemia sparing the pupillary fibers. So the take-home messages are: assessment of pupil helps a lot in the diagnosis of many ocular and neurological diseases. A careful examination of pupil for even subtle changes plays a key role in diagnosis, which even may be life-saving or vision-saving for your patient with early interventions possible. Thank you.
Thank you, Dr. Dalia, for that wonderful presentation. She made the pupil in a nutshell. So we can understand how the importance of examination of the pupil. Sometimes it may be life-saving, as in head injury. So avoid the last sentence written by Dr. Dalia, avoid mydriatics if possible in all cases of head injury, because we can miss a Hutchinson's pupil.